All right, today we're diving into a real-life medical detective story. And this one's a bit of a paradox because the most dangerous clue is something you'd never, ever expect. Let's jump right in.
So let me ask you something right off the bat. When do you go to the doctor? Usually it's because something hurts, right? Pain is our body's alarm system. But what if the biggest, loudest red flag was the absence of pain? Just silence. Keep that question in your back pocket because it's central to everything we're about to talk about.
Okay, so our story starts, like so many in medicine, with the patient. But the set of symptoms we're about to see, well, it's not just a little weird. For any doctor who knows what they're looking at, this is a 5-alarm fire. The alarm bells should be ringing off the hook. So meet our patient. He's a 63-year-old guy. He comes in because he just knows something is off. Something is deeply wrong with his body. But here's the kicker. He's not in any pain. And that right there, that's our first and maybe our most critical clue in this whole mystery. Okay, so what are the clues? Well, it's this very specific quartet of signs. First, he's got jaundice. His skin and eyes are turning yellow, but it doesn't hurt. Second, his stools are a strange pale clay color. Third, a doctor can actually feel his gallbladder and it's not tender. And finally, he's lost a lot of weight without trying. You put all those together, that is the classic textbook signature for something called malignant obstructive jaundice. It's a huge, flashing neon sign.
So how can we be so confident just from those clues? Well, this is where we put on our detective hats and really start decoding what the body is telling us. Each one of these silent clues has a story, a biological reason behind it, and together they point to one culprit.
Okay, so here's the chain reaction step by step. Deep inside, a tumor is growing in a very specific spot, the head of the pancreas. Now think of the common bile duct like a tiny garden hose. As this tumor gets bigger, it starts to slowly, gradually, almost gently step on that hose. It's not a sudden kink, it's a slow squeeze. And what happens? The bile can't get through. It backs up, and eventually spills over into the bloodstream. That's what causes the jaundice, the yellowing of the skin and eyes.
And this gets us back to our big question. Why is it painless? It all comes down to the speed of the blockage. You see, a gallstone is like a rock suddenly jamming the works. It's a violent, acute event. The body freaks out, you get inflammation, painful spasms, and very painful jaundice. But a tumor, it's slow, it's gradual, it's relentless. The body kind of gets used to the pressure, so there's no acute inflammatory freakout, no spasm, no pain. That eerie silence, that is the red flag.
All right, next clue, the clay-colored stools. This one is actually pretty straightforward. It's just basic plumbing and chemistry. The stuff in bile is what gives stool its normal brown color. So, if the bile duct is blocked, no bile gets into the intestines. And if there's no bile, there's no brown pigment. The result? Pale clay-colored stools. It's a dead giveaway that the system is blocked up high.
This brings us to one of those classic physical exam findings that gets its own name. It's called Courvoisier's sign, and the rule is simple but powerful. If you have a patient with jaundice, and you can actually feel their gallbladder, you have to think malignancy, not gallstones. So why is that? What's the logic here?
Well, it's all about the history of the gallbladder itself. Think about it. A gallbladder that's been dealing with gallstones for years is usually inflamed, scarred down, and kind of stiff. It's fibrotic. So when the pressure builds, it just can't stretch. But in our patient's case, the gallbladder was probably perfectly healthy before this started. So as the bile backs up from that slow-growing tumor, the healthy, flexible gallbladder wall just distends. It blows up like a little water balloon, and that's why a doctor can feel it.
So at this point, the clinical suspicion isn't just high, it's through the roof. The detective has pieced together the clues at the scene. Now it's time to go to the forensics lab, or, in medicine, the radiology department, to get the hard evidence to confirm what we already strongly suspect.
And the first stop is almost always an ultrasound. Why? Because it's quick, it's non-invasive, and it gives us a fantastic look at the plumbing. And sure enough, an ultrasound would show exactly what we expect. The bile ducts are all swollen and dilated. That confirms the blockage is distal, meaning far down the pipe, right in the neighborhood of the pancreatic head.
But the real heavy hitter, the key test, is a contrast-enhanced CT scan. This is the big one. We're not just looking to see the tumor anymore. We already know it's there. The CT scan answers the most critical questions of all. How big is it? Has it spread to other places, like the liver? And maybe most importantly, is it tangled up with any of the major blood vessels in the area? The answers we get from this scan will literally determine the entire path forward. And that brings us to the moment of truth, the verdict. All the investigation, all the clues, all the imaging, it all boils down to one single, critical question that creates a massive fork in the road for the patient. Is this tumor operable? So, here are the two paths. Path number 1, resectable. If that CT scan shows the cancer is localized, it hasn't spread to distant organs, and it's not wrapped around major arteries, then we can go for it. The goal is surgery, the goal is a cure. But path number 2, unresectable. If the cancer has spread, or if it's hopelessly entangled with those big blood vessels, then a big surgery is no longer an option. The goal completely shifts to palliative care, which means focusing on comfort and quality of life. Now, for the lucky few who are on that curative path, the solution is an absolutely massive operation called the Whipple procedure. And when I say massive, I mean it. Surgeons go in and remove the head of the pancreas, a chunk of the small intestine, the gallbladder, the end of the bile duct, and then they have to meticulously replumb the whole digestive system. It is one of the biggest, most complex surgeries in all of medicine, but it's also the only shot at a cure. Now, what if the tumor is unresectable? Well, the focus immediately pivots to making the patient feel better. That jaundice, for example, causes absolutely maddening, relentless itching. So doctors can go in with an endoscope and place a tiny stent to prop open that blocked bile duct. The bile starts flowing again, the jaundice goes away, and that awful itching stops. It's a huge quality of life improvement. And then, of course, there's chemotherapy to try and slow the cancer down. Okay, let's zoom out for a second. We've been focused on this one case, this one detective story. But what does it tell us about the bigger picture? This whole journey really shines a spotlight on why pancreatic cancer is such a tough adversary. It's because it's a race against a clock that you don't even know has started.
Here's the fundamental, heartbreaking problem with pancreatic cancer. Because it grows so silently, without any pain to sound the alarm, by the time symptoms like jaundice finally show up, the tumor is often already quite large and has had a long time to grow. For way too many people, by the time the first clue appears, the disease is already in an advanced stage.
And that leads to a really sobering number. When you look at all patients at all stages of pancreatic cancer, the overall 5-year survival rate is less than 10%. It's one of the most lethal cancers we face, and the number one reason is that it's just caught too late. But, and this is the glimmer of hope here, this is the whole point, for that small group of patients whose cancer is caught early enough for that big Whipple surgery, the survival numbers are significantly better. And that's why this medical detective work, recognizing these silent clues for what they are, is so unbelievably important. It's not just an academic exercise, it's what can actually save a life.
Which brings us full circle, right back to the beginning. If you take away only one thing from all of this, let it be this clinical pearl, this mantra. Painless, progressive jaundice in the elderly means malignancy until proven otherwise. Having that thought process, that high index of suspicion that's triggered not by pain, but by its eerie absence, that's what gives patients a fighting chance. That is how you solve this mystery and, just maybe, save a life.